few moments about the pathology. So, this case is about a young girl, which we examined in our institution on two separate occasions. The first time we examined her, she was 2 days old, and we knew already about her from her prenatal ultrasound that she had right kidney hydronephrosis. And we examined her as a follow-up before discharging her from the hospital. So this is her first ultrasound. As you can see, she has right kidney hydronephrosis. The left kidney seemed normal, and her pelvis ultrasound with the urinary bladder was also normal. The second time she came was 1.5 months later. She came to the ER. She was very lethargic. She had anuria and hyperkalemia. We started with an ultrasound exam. It was the second ultrasound exam. And as you can see, the hydronephrosis got worse on the right side. There was new hydronephrosis on the left side. And in the abdomen, almost everywhere we saw free fluid, around the right kidney, the left kidney, and around the bladder. At this stage, we suspected that she had a lower urinary tract obstruction. So we did a voiding cystography, and these are the pictures from her cystography. You can see the dilated urinary bladder, with pouches and trabeculation. This was taken during her micturition phase, and then we saw there is a stricture in the urethra. Our working diagnosis now was that she had some kind of urethral stricture that causes the obstruction. Because of the free fluid in the abdomen, we decided to do a CT as well. And this picture is from the early phase scan. You can see the hydronephrosis on both kidneys, the right and the left. The large amount of free fluid in the abdomen and in the perinephric area. These pictures are from the extractory phase. You can see extrication of urine coming from the area of the renal pelvis, the urethra, and you can also see in the right kidney fluid levels because of the obstruction. This girl was sent to surgery, which confirmed our diagnosis. And in fact, they did see the stricture in the urethra. So a few words about lower urinary tract obstruction. It has a nice short name, LUTO. It is defined as a partial or complete obstruction of the urinary tract at the level of the bladder or the urethra. It is considered a rather rare birth defect that occurs only in 1 in 5,000 to 7,000 births, mostly in males. About 2/3 of LUTOs are diagnosed antenatally, and unfortunately carries a relatively high fetal and neonatal mortality, about 50% of the untreated cases. In these illustrations, we can see the pathology more clearly. This is the pathology of urethral atresia. We can see complete obstruction of the urethra. This pathology is most common in female. The posterior valve is a flap of tissue that blocking the urethra. This is the most common pathology in males. And in this illustration, we can see basically what was happening in our case, which is just a constricted narrowing of the mid portion of the urethra. I There are many other causes for luto. I'm not going to talk about all of them. I just want you to know that some of them are isolated, such as the posterior urethral valve, and some of them come with many other birth defects, such as the prune belly syndrome. The list is quite long. What are the clinical presentation? Well, in the severe obstruction cases, they are usually diagnosed antenatally, and then we would see a fetus that is small for its gestational age, and we might also see oligohydramnios and the associated abnormalities, which we would talk about in a second. In the less severe cases, they are usually diagnosed only in early infancy, and we would see mostly urinary tract infections. So let's talk a little bit about the radiographic features. In the antenatal ultrasound, we may see marked distension and hypertrophy of the bladder. It may come with or without hydronephrosis and hydrourethra, and depending on the severity of the problem, there might be oligohydramnios and renal dysplasia. If the oligohydramnios is very severe, there can also be pulmonary hypoplasia and club feet. It is also known as the Potter sequence or syndrome. Postnatal ultrasound. Basically, we would see the same finding, but when we diagnose this postnatally, it usually means that the pathology is less severe, and the finding would be less evident than the antenatal ultrasound. The same, the bladder would be thick-walled and trabeculated, as we saw in our case. The kidneys are usually hydronephrotic, but in 10% of the cases they are not. They seem normal. In severe cases, there is renal dysplasia and hyperechoic loss of the normal corticomedullary differentiation. And in the specific case of posterior urethral valve, we would see an elongated, dilated posterior urethra, which gives the shape of a keyhole, and it's called the keyhole sign. Okay, sometimes we also have complications. The complications can be a rupture of the urinary tract due to the increased pressure during micturition. It depends where the rupture is. We would see the accumulation of fluid. If it is near the fornix, we would see perirenal, pararenal urinomas. If it's near the bladder, we would see intraperitoneal fluid. Voiding cystoid retrogram it's the best diagnosing tool when it's done during the micturition phase, because then we can see the urethra. In 50% of the cases, we can see vesicourethral reflux. We would also see the bladder trabeculation and the diverticula, and of course the narrowing of the urethra. So what are the treatment and the prognosis in this kind of problems? Well, the good news, there is an antenatal treatment. It is consisting of vesicoamniotic shunting. What they basically do is, using ultrasound, they insert a shunt through the abdominal wall of the fetus, and it lets the urine out of the bladder, bypassing the stricture in the urethra. Postnatally, of course, there are definitive treatments which involve in the posterior urethral valve transurethral ablation, and in the more severe cases, there is urethral reconstruction as well. As for the prognosis, it's primarily affected by the degree and the duration of the obstruction. In the less severe cases, when the renal function is normal, there is a very good prognosis. In the severe cases, there might be a renal damage. The changes are causing cystic renal dysplasia, oligohydramnios, and pulmonary hypoplasia. In these cases, it may even be incompatible with life. That's it. Thank you very much.